I'm doing my talk as a review of the clinical practice guidelines for the treatment of central disorders of hypersomnolence. So the outline for this talk and the objectives to provide the AASM recommendation guidelines for the treatment of central disorders of hypersomnolence, and to go over the therapies and conditions that did not have sufficient evidence to support a recommendation. And I'll also be discussing some of the cardiovascular risks that are associated with the weight promoting agents and the stimulants. So here is an outline of all of the disorders that are both discussed and not really discussed in the guidelines. So for the first disorder is adults with narcolepsy. Here is a big table that goes over all of the recommendations. So the task force divided the recommendations into strong, meaning that the clinician should go with one of these medications under most circumstances, and conditional, meaning that the clinician should use their judgment in addition to the patient's preferences to come up with a plan that worked for that particular patient. So the first medications that have strong recommendations, the first one is modafinil. Unclear on the mechanism of action, but it's likely to bind the dopamine active transporter to inhibit dopamine reuptake, and it is the racemic mixture that includes the R enantiomer, modafinil. The task force found that after reviewing the studies that excessive daytime sleepiness, disease severity, and quality of life were all clinically significantly improved. Adverse outcomes for this medication were insomnia, nausea, diarrhea, headache, and dry mouth. The next medication with a strong recommendation is pitolisant, which is an H3 antagonist and inverse agonist. It showed improvement in the studies that the task force looked at in the excessive daytime sleepiness, as well as cataplexy and disease severity. The adverse events with that medication were headache, insomnia, weight gain, and nausea. The next medication, sodium oxybate, is a GABA metabolite. It showed improvement with excessive daytime sleepiness, as well as cataplexy and disease severity. The adverse events associated with this medication were nausea, dizziness, nocturnal enuresis, headache, chest discomfort, and sleep disturbances with sleep disordered breathing reported. Those were for the randomized clinical controls. The randomized control trials with the observational study showing sleep disturbances, headache, nausea, dizziness, and confusion. The last medication that received a strong recommendation was solriamfetol, which inhibits the reuptake of dopamine and norepinephrine. There were clinical improvements in excessive daytime sleepiness, as well as disease severity and quality of life. The adverse events associated with that one were headache, decreased appetite, insomnia, nausea, and chest discomfort. And then for the conditional recommendations, the first one was modafinil, which is the R enantiomer that's isolated from modafinil. That showed improvement in excessive daytime sleepiness and disease severity. The adverse events with that medication were headache, and then kind of the unique ones were URI and sinusitis. There was also noted somnolence with that medication, and then dizziness and nausea, which are pretty common in all these medications. Then the traditional stimulants were conditionally recommended. So dextroamphetamine, that and methylphenidate both inhibit the reuptake of dopamine and norepinephrine and promote their release via their respective transporters. But dextroamphetamine improved excessive daytime sleepiness and also has effects on cataplexy. The adverse events were sweating, feeling on edge. Interestingly, weight gain was one of the adverse events. There's also loss of appetite and irritability. For methylphenidate, there was an improvement in the disease severity alone. And the adverse events that were related to that medication were noted to be with long-term use, and those included dry mouth, sweating, headache, loss of appetite, and stomach discomfort. As far as medications or therapies that were that did not have enough evidence to gain a recommendation, these include L-carnitine, some that we frequently use in clinic or scheduled naps for narcolepsy and SNRIs. These did not have enough evidence to support a recommendation. Selegiline, triazolam, and then SSRIs. And then to look at the safety of stimulants.
Just for the sleepiness effect?
Those for the narcolepsy. They didn't really differentiate type 1 and type 2. They just kind of lumped them all together.
People use them for cataplexy.
So looking at the safety of stimulants, so first the traditional stimulants. So this paper looked at a cohort of residents in Ontario who were at least 66 years old. These people were starting a stimulant. They were called the exposure group, and their stimulant was initiated in this accrual window from January 1, 2002 to March 31st, 2015. And they designated these people as initiation, meaning that they did not have a prior stimulant prescription within the past 365 days. They looked at the primary outcome being any kind of cardiovascular event that led to an ED visit or a hospitalization for an MI, stroke, TIA, or ventricular arrhythmia. And then they underwent a secondary analysis, and they looked at each of those primary outcomes individually, as well as the all-cause mortality. The individuals were followed until they met one of those primary outcomes, death, they discontinued the stimulant, or the follow-up period ended, which was in March of 2016. So for this study, they looked at 6,457 older adults who were exposed to stimulants, and they matched them with 24,853 unexposed individuals. The median age for either group was 74. And so for the primary outcome, they saw that there was a statistically significant higher risk of having a cardiovascular event at 30 days for those who had started the stimulant. And they found that there was a 40% increase in the first 30 days, with the most likely events being a ventricular arrhythmia, stroke, or TIA. When they looked at these people at 80 days and 365 days, they did not see that this effect carried over in the longer duration.
So does that mean you just gotta survive to 30
Yeah.
days?
That's what it looks like.
No, I'd say it must be that those are the susceptible people, but it didn't tell you what purpose of giving the stimulant was.
Right.
At least not yet.
Yeah, they just said for various uses.
Right.
Yeah, so it could have been dementia, could have been sleepiness.
I mean, there's at least in geriatrics, they pull out Ritalin a lot to try to prevent going into a nursing home. So if they can get Ritalin in the morning so that people can get dressed, that's going into a nursing home for about 6 months. But I've never seen a paper. It's just lore. Interesting.
So in this review, they looked at the limitations of the study, and they saw that They didn't have any access to the patients or the individual smoking history, their alcohol use, or their BMI. They also didn't have information as to whether these people were maybe receiving samples before they got a prescription, or if they were involved in some kind of drug trial prior to an actual written prescription. They also said that it's possible, although they said that it was very, very unlikely that the initiation group, so those who had started or who had not been on a stimulant in the past 365 days, perhaps they had been on a stimulant more remotely. So were they actually initiating a stimulant? They also did not look at a dose-dependent response, and they were not able to see why the patient discontinued the medication. The other medication is the wake-promoting agent modafinil.
Of those things, there were 7,000 people who were sleepy enough to consider stimulants. It's not because they were in clinical trials. You're not gonna have huge numbers there.
No, yeah.
So it's-
I don't know who's
They were
giving
just
out.
grabbing at straws.
Yeah, no one's giving out Adderall samples, so. I don't know. So as far as the safety of modafinil, this paper looked at 6 randomized, double-blind, placebo-controlled parallel group studies. And the studies were all supported the efficacy of excessive daytime sleepiness being helped with modafinil, but the indications were different. So they had chronic shift work, sleep disorder, OSA, and narcolepsy. And so in each of those 6 studies, it was 2 for each indication. There were about 80% of patients that actually completed the study. So there were a total of 1,529 patients who were randomly assigned to either the placebo group or the modafinil group, and 1,261 patients actually completed the studies. The dosing and the duration of all these studies were different. So for the shift work sleep disorder, both studies were 12 weeks long. One study looked at modafinil 200 and the other looked at modafinil 200 and 300. For the OSA indication, they had modafinil 200 and 400 groups. That study was 12 weeks long, and then they had a modafinil 400, which was a 4-week long trial. And for those, the patients were titrated to the target dose in 2 to 9 days. Same as far as the titration for narcolepsy. For this indication, patients were on modafinil 200 and modafinil 400, and those trials were 9 weeks. So they included patients who were at least 18, if they had a complaint of excessive daytime sleepiness, and they were within the upper age limit for the individual studies. So for the shift work sleep disorder, that meant 60 years old. For OSA, it was 65 or 70, and then for narcolepsy, 65. So for the cardiovascular effects of modafinil, they looked at patients when prior to starting the medication and then at the last visit. And they found that for shift work sleep disorder and OSA, there was no significant change in the heart rate, systolic or diastolic measurements from baseline in the modafinil group or the placebo group. Sorry, I don't know why that box kind of cuts off the numbers. But when they looked at the narcolepsy group, they found that there was a statistically significant difference in the heart rate and the systolic pressure. That was because in the placebo group, there was a greater change compared to the baseline when they looked at them versus the modafinil group.
What was the change?
The heart rate and the systolic, those were, if you look at the.
Or I guess by how much?
So they didn't really they just showed the table. It wasn't, let's see.
That's age, that's
Yeah, that's
age,
not-
age, men, race, white, other, BMI combined. This must be no, next one might be
Um,
mixed up 1 and 2.
Okay, so for the,
Here's the values part.
no, there's another slide. I'm not sure.
That's just
Well,
who was in it. This is
yeah,
what happened.
So in addition to looking between baseline, and the end of the studies, they looked at, or they kind of set out with these, clinically meaningful, parameters as far as what was a significant change. So they looked at the heart rate and they said that, at least 120 and an increase from baseline of at least 15. Then they looked at the systolic pressure and they said at least 180 with an increase from baseline of at least 20. And then diastolic pressure of at least 105 with an increase from baseline of at least 15. And so they found that there were 9 patients in the modafinil group, which came out to be less than 1%. Who had who met those significant adverse events or effects of the diastolic blood pressure. There were 0 in the placebo group. They also obtained an EKG at the before starting modafinil and then at the last visit. And they found that there were changes from baseline, but there wasn't a significant difference between the modafinil and the placebo group. It was 17 and 18%. They also looked at whether people had to initiate or increase the dose of their antihypertensive. And they found that in modafinil patients, there was an increase in 2.4 versus a 0.7 for the placebo group. So overall, the modafinil didn't really elevate the mean blood pressure or heart rate more than the placebo. The studies that were included were only 4 to 12 weeks, but I guess if we go by the 30 weeks, like the
30
stimulants.
30 days. Right?
Sorry, yeah, 30 days of
Right.
the stimulants, maybe there's a similar effect. So as far as the, just looking at the adverse events of modafinil, the discontinuation rates for those who received the modafinil versus the placebo were very similar, 18 versus 16%. And thought this was interesting. Actually, the 300 milligram dose was discontinued most. So 34% discontinued at 300, 18% stopped at the 200 dose, and then 15% stopped at the 400 dose. They also looked at the duration of modafinil use before stopping, and they saw that the shift work sleep disorder patients stopped at an average of 42.3 days, narcolepsy at 60, and then the sleep apnea group was at 65. They found that the only adverse event was headache, that was dose related, was headache.
Is that your experience? People stopping modafinil. Usually 2-3 days later, they get usually headache and nausea, but headache is probably. Just trying to think of how it maps to people I've seen, what they do and how they use.
They also looked at labs. So when they looked at blood and urine before starting modafinil and then at the last visit, the only real difference they found was in the narcolepsy group, the GGT and the alk-phos were elevated in the placebo group, or sorry, in the modafinil group when compared to the placebo. But it was a less than 1% that had clinically significant elevations. They also said that there was less than 1% of patients in all the studies that had a clinically significant abnormality in the labs that they looked at. So the ALT, AST, BUN, creatinine, uric acid, and the T-belly.
Did they make a recommendation or not on whether you should draw blood levels
They didn't.
at 30 days? I mean, there's none that I know of.
No, I mean, you can ask for that here if you wage for blood modafinil.
No, just the,
Oh, the LFTs.
Yeah, the LFT, I mean, we don't do that routinely.
I'll just check before.
Yeah, okay.
I've only had one case I can recall where I've seen LFT elevations. And they were not clinically severe. So no cause of it.
Yeah.
Okay, so the next disorder, patients with adult patients with idiopathic hypersomnia. So for this disorder, the only medication that has a strong recommendation is modafinil. It improves the excessive daytime sleepiness and disease severity for patients, and then same side effects. The other medication with a conditional recommendation that I haven't seen, I don't think used in clinic, is clarithromycin. The mechanism of action for that one is GABA A negative allosteric modulator, and it was found to improve excessive daytime sleepiness, disease severity, and quality of life. Obviously, since it's an antibiotic, it had some GI symptoms. It also had dysphagia or dysosmia. There's also insomnia, diarrhea, and nausea. Methylphenidate is another conditional recommendation, and that showed improvement in disease severity. Same long-term adverse events. Pitolisant, there was improvement in excessive daytime sleepiness, same adverse events as the other recommendation, the narcolepsy recommendation. And then for sodium oxybate, excessive daytime sleepiness was improved. The RCT showed that there was evidence of some sleep disturbances, nausea, dizziness, and then urinary and renal disturbances. There was also headache and chest discomfort. And then in the observationals, there was, again, sleep disturbances, headache, nausea, dizziness, and confusion.
Which has FDA approval for idiopathic hypersomnia, is it?
It does,
Sodium oxybate?
it does have, yes. However,
Pitolisant as well? No?
pitolisant, I believe
Oh.
does.
And sodium oxybate.
Sodium oxybate does for sure, but it's still just got the conditional.
I've tried clarithromycin. People don't like to take it because it's an antibiotic and they have confused is why I'm even giving this.
As far as treatments that they did not provide a recommendation for flumazenil.
But it is interesting.
It is interesting, yes.
Yeah, the Emory group uses a lot of, and they use a compound pharmacy to make a longer acting flumazenil to be able to treat idiopathic hypersomnia. So it's a really interesting approach.
Yeah, I think it's a sublingual.
Yeah, sublingual and all sorts of stuff. So it sort of shows you that you can be pretty inventive with pharmacology of these disorders.
For adult patients with Klein-Levin syndrome, the only medication, and it has a conditional approval, is lithium. The mechanism of action is unclear, but it's likely to upregulate glutamate reuptake to have its effects. It was found to improve disease severity, and the adverse events are tremor, polyuria, polydipsia, diarrhea, subclinical hypothyroidism.
Has anybody seen a Klein-Levin issue?
Mhm.
Yeah, I mean, the problem with this particular drug and how it is that it has various lengths of when you have this relapsing hypersomnolence. And so how do you know if they're gonna get better? So they give the drug and they get better. And then they say, well, they get better faster than they did before, compared to what? And it's really difficult to know what the lithium sort of effect is. And you're giving it to a lot to kids. I mean, or under the age of 18. I mean, we haven't seen one in a long time. I don't know why. Should be present in the population of that we sort of. Should ask the Cleveland Clinic if they see.
The task force could not recommend for or against IV methylprednisolone for adults with this disorder. Then the next group of disorders are hypersomnia due to a medical condition. So the first one is.
So why would you use methylprednisolone for level? I mean, why did somebody dream that up? I mean, you know, somebody's sitting there going, they're really stubborn problem and they're doing it again. I want to give them this.
I feel like steroids are,
Yeah, steroids. And it's usually pediatricians think
Just
that they're
those
doing
steroids.
that. And in China, Faghan says they give, you know, IVIG and they do all sorts of stuff and they plump up the kids until they're with the prednisone until they're jumbos and all that sort of stuff. He says it's terrible. Then they walk in and they say, get rid of all this stuff.
so for the alpha-synucleopathies, there are only conditional recommendations. So for, dementia with Lewy bodies, armodafinil is recommended. It improves excessive daytime sleepiness, same adverse events as the other indications. And then for Parkinson's, modafinil and sodium oxybate are both recommended.
Sorry, so
Yes,
what's the indication here in this?
this is for the,
Sleepiness in the setting of alpha-synucleopathies. I mean, you
So
know,
look at that, why did they look at that specific?
there's a literature on it.
That's-
People throwing some drugs at them and trying to figure it out.
Something to do with medical disorder.
they could not, recommend for or against light therapy, and that was only for Parkinson's. They didn't, mention any other, alpha-synucleopathy.
Was any of that in any of the questions yesterday?
Sorry?
Oh, you took an exam yesterday, right? Any hypersomnolence questions?
Oh, yeah.
Yeah, did she answer? Oh, okay. Just face validity, that's it.
Yeah.
Good.
So hypersomnia, from post-traumatic, condition. So, TBI, you can use armodafinil or modafinil, and there's a conditional approval for either medication. Same adverse events, excessive daytime sleepiness was improved, with both medications. So looking at genetic disorders, that are associated with a primary CNS somnolence, they provided recommendations for myotonic dystrophy. And they said that modafinil was, recommended to help with the excessive daytime sleepiness. The recommendation, or they could not provide recommendations for or against methylphenidate or selegiline, and these were only for myotonic dystrophy. So the next category of hypersomnia due to medical conditions is brain tumors, infections, or other CNS lesions. And the only medication here is modafinil, and the only indication is for MS. It improved excessive daytime sleepiness. They only mentioned hypersomnia due to an endocrine disorder, and the only endocrine disorder mentioned was diabetes, and the only thing that they said was we cannot recommend for or against liraglutide.
I don't know the literature on that. I mean, type 2 diabetes is so common. Even if there was 1% of excessive daytime sleepiness, we'd be seeing a lot of it.
I kind of wonder when they did the let's search if they really were looking for hypersomnia or they.
Just sleepiness, right? Yeah.
Like renal disease secondary to.
But that
They
would
didn't
be,
really say.
that would be in their search section in methods, say we use these terms, so when they generally don't tell you what terms map to this, to the diabetes, they
Yeah.
don't tell you what term. Maybe that'd be fun to look at. Right, or we could ask Stephanie if she's on, Dr. Griggs, if she's on, is that right? Oh, no, Okay, anybody? Oh, good, okay.
I'll look at then. So, the other, hypersomnolence due to medical condition that they mentioned was a psychiatric disorder, and they could not recommend for or against modafinil and light therapy.
What year was this?
2021,
2021.
yes.
All right.
So for pediatric patients, this is where things get real short.
That could be any kid.
Yeah.
That goes to sleep.
So for pediatric patients with narcolepsy, the only medications that they provided a conditional recommendation for were modafinil and sodium oxybate. The modafinil did improve excessive daytime sleepiness. The adverse events, again, headache and nausea and dry mouth, but also irritability. Sodium oxybate for the pediatric population, they found it improved excessive daytime sleepiness, cataplexy, and disease severity. However, it did have adverse events including weight loss, enuresis, nausea, vomiting, headache, decreased weight, decreased appetite, nasopharyngitis, dizziness, and then some rare and serious events, so centrals, depression, and suicidality. The task force could
I
not,
would think that that was the sodium
the sodium content,
formulation, because it tastes terrible,
the suicidality.
right? I mean, yeah, the weight loss thing. And
Oh,
your
the weight loss.
and your reasons you can explain.
Yeah,
Because
yeah.
you're just sleeping.
Yeah.
Vomiting. Headache, weight
Um,
loss and decreased weight, which one is which?
the task force could not make recommendations for or against. Here's the IPIG. Methylphenidate, amphetamines, scheduled naps, SSRIs, or SNRIs. They had no recommendations for or against any other pediatric condition. So that's why they're all gray. Here are my references. We do questions.
Right, right? Uh-oh, you got questions.
I did.
That's good, that's.
Oh, wait.
Don't worry. We'll figure it out.
This one's-
Conditional. Oh. Now, so I had a couple of interesting things which always come up. Just wonder about, maybe you found something in there about sinusitis
Mhm,
and what was the other one? Nasopharyngitis.
mhm.
I have no clue why you would get that in any of these alerting agents. And there are a couple of them. Sodium oxybate's one of them, and the other one is.
I wonder if it's because it's drying. I don't know.
I don't know. I mean, we know very little about that sort of stuff. And what was the second? Sweet thing? Oh, you know, the sodium oxybate and the sleep disordered breathing is getting a lot of, at one time got a lot of press. And there are some people, there are some physicians early on really noticed that that was going on. The initiation of sleep apnea in people that did not previously have it in narcolepsy without weight gain. And so that's a problem there. And in any person that has a hypoventilation syndrome, you gotta use that cautiously. That's the other thing that they may not have picked up, because these are all case reports, and they don't really, you notice in the methods, they all take the case reports and sort of sweep them under the rug,
Mhm.
because they don't know what to do with them. What else? Oh, 30 days.
Mhm.
Anything in children?
The only study I saw, that one that included children, and then that one they did mention the 30 days. But I was trying to
Yeah.
focus more on.
So Farhan did a study in narcoleptic children, gave them, did 24-hour blood pressure recordings before and then after 20 milligrams of Ritalin,
Mhm.
maybe it was 40, and showed that the blood pressure in control was actually lower than the control group that they had.
Hmm.
And that it increased the And there was no dipping. So that was two things. Blood pressure was a little low. And there was no dipping in the narcoleptic controls. You give them Ritalin and their blood pressure is up, but now they have dipping. So now you get into that sort of like, well, the blood pressure's up, but it's in the normal range. And then you have dipping, and dipping's supposed to be good for cardiovascular health. And so it was sort of like an interesting sort of scratch your head sort of phenomenon that if you start to go by the book, it's hard to know those things. And there's a article gonna be coming out of solriamfetol and its effect on 24-hour blood pressure in the trials for solriamfetol for epilepsy. It shows a similar thing, although there's not a really good control group that they have for that age group. So it's a question of, and in animal models, the lack of orexin produces a lower blood pressure, lower. So you kind of go, okay, but people get really concerned about it. FDA in particular, because of this literature, gets really concerned about reporting heart rate and blood pressure and all these drug trials. So what's the alerting drug of the future? People don't know. People are thinking of combination, drug companies are thinking of combinations, smaller doses, but combined stuff, because you hit dopamine, and you hit, and you hit, a GABA antagonist. So you can think of those for when you're awake. When you're asleep, there's not much other than this crazy drug, sodium oxybate. And why do you think it works on cataplex? We gotta think about
Yeah.
cataplexy networks, right?
The GABA.
Goes from goes down to your brainstem, and your brainstem goes down to your motor nucleus. To be able to produce cataplexy and keep your cortex awake. So it's that really odd little system. I don't know if. And the interesting thing is that the sleepiness comes back before the cataplexy when they stop these drugs. So the cataplexy is inhibited for another 2-3 weeks. And the sleepiness comes back in a week. So that sort of makes you scratch your head too. Just how little we know about these things. That's all. I don't think anybody has done functional MRI in provoking a cataplexy, right?
Yeah.
What do? You have, Henny Youngman saying jokes in the MRI and trying to see if you can get them laugh at that. Right?
Maybe it's a dose dependent, because cataplexy usually comes second. I don't know.
Louise Flygate said that her cataplexy came first, but she probably was ignoring her sleepiness. Right? She's just a tough kid. But so that's good. All right, we got a little time left. Do you want to talk about your test yet?